I'll just start by thanking colleagues at University Hospital for their hospitality today and the use of their boardroom. We're very keen to get around the patch and host meetings. We've done one in Stoke. We'll be doing, I think, the next meeting or the meeting after at Staffordshire County Council headquarters. And I know, Neil, we've already been to MPFT, and we'll do the same with Combined over the course of the cycle. So just begin, if I can, by saying we've got some new board members. I'm going to do introductory welcomes during the Chair and Chief Exec report, if colleagues are happy with that. Staffordshire and Stoke-on-Trent integrated care board meetings are meetings in public. They're not public meetings. And I just ask for everybody joining us online today, if you wouldn't mind just putting your camera off and your microphone on mute, and then we will invite you to come back on camera and microphone should you wish to raise a question in due course. I will give members of the public an opportunity to ask questions that have been submitted in advance at the start of the meeting in a few moments' time. There'll also be another opportunity at the end of the meeting to actually ask any questions on any item that's been covered across the agenda today. Okay, Tracy?
Yeah.
So apologies we've received, Kate, for today. If I can just check that. That's Paul Edmondson-Jones and Lorna, thank you for covering. We've got John Rouse and Patrick Flaherty and also Julie Holder. I've no other apologies recorded. Thanks, Kate. So we're okay with that. Enclosure 1, we have the Leadership Compact, an important document that is used in all of the meetings transacted across the ICB and the wider ICS, and it guides the way that we conduct our business. And we'll return to that at the end of the meeting to just double check that we have actually done that. Paul, I think we are now quorate with Bucky's arrival, so welcome, Bucky. Very pleased to see you that we can be quorate for today's meeting. So if we could just move into conflicts of interest. Any member of the board wishes to raise a conflict that's not already been disclosed to Tracy? No, thank you very much. So we'll move, if we can, to enclosure 3, the minutes of the meeting held on the 20th of June. We'll take those for accuracy first, if we can. Page 1, page 2, page 3, page 4, 5, 6, 7, 8, 9, 10, 11, 12. The board content with the accuracy of the minutes from the previous meeting held on the 20th of June. Thank you. In terms of the action log, Heather, we've got one that's due to come back, I think, in September around the birth trauma inquiry report, and you'll bring that report in September.
I will, Chair, yeah.
Thanks, Heather. Other than that, I think we are clear in terms of outstanding actions for today's meeting. So on to item 6, and Adele, can I just ask you or Tracy to read out the questions that have been submitted in advance to the...
Yes,
Tracy.
I can do that. So these questions have been asked by Paz Tameeds from Health Watch. So the first one, Health Watch Staffordshire, is during our recent engagement activities out in localities, Health Watch Staffordshire have been speaking to people about the experience and understanding of the model of virtual wards. Our feedback suggests that knowledge and understanding of this initiative is low within local communities, and people are questioning how this might work. Can the ICB describe what steps are being taken to raise awareness of this initiative amongst the local population so that public will gain confidence that virtual wards will offer them as good a quality service as that of an inpatient on a real ward?
Thanks, Tracy. Phil?
Yeah, thank you. Thanks for the question. So improving the utilisation and capacity of virtual wards is absolutely central to our urgent and emergency care strategy, and also specifically in our demand management system collaborative. It's a model we're absolutely to, and there are many facets to making it a success. One is around having the right workforce. One is having the right culture within our system so that clinicians trust and use the service. And then the other part, as you rightly highlight, is around public awareness So we have a system virtual ward group which meets, and a work stream has been established feeding into this around education and communication. And we're currently contacting our partners in Healthwatch and VCSE to include them to support this work stream and guide how we inform and improve understanding to our population of virtual wards.
Thanks, Phil, for the clarification there. Thank you to Baz for the question. Tracy?
Second question again from Baz is Healthwatch Staffordshire, through its networking with other organisations and services, has made contact with a number of services providing home from hospital support for patients to enable discharge from hospital or prevent admission. The type of support offered is very similar with a few variations. Many of these services, we were told, are funded through monies from the ICB. None of the services we spoke to seemed to know the existence of the other similar services. So I'd now real opportunity to target resources to reduce duplication, but also to maximise resources to best effect. Are there mechanisms in place to ensure that these very valuable services are coordinated to achieve maximum reach and impact and ensure that services are focused and avoid duplication?
Okay, thank you for the question again. So yes, absolutely right. We've got a number of services supporting home from hospital. The one that immediately springs to mind, which I read a paper on yesterday, is the service that Staffordshire Fire and Rescue provide, and they've supported 900 discharges since December, which has been really, really fabulous in terms of both transportation and settling in. But as you say, there's numerous services that do this. In our health and care system, we have an integrated discharge hub, which is made up of local authority and NHS partners, which seeks to coordinate and ensure timely discharge from hospital down the right pathway. From this month, we're going to be including VCSE representatives in that team. So that will help both in terms of the awareness of those pathways, the utilisation of them, and also support the development of the pathways to ensure we're not duplicating and we're learning as we move forward. Thank you.
Thanks, Phil.
The next question again from Baz to me is, we are hearing from many people who are being excluded from GP surgeries as they come across as being unreasonable. From our interaction with people, we feel that they have deep-rooted medical needs. What is being done to ensure such people have access to the primary care services they need?
Well, that's okay, Chair. So thank you for the question, an important one. So the removal of patients from general practice lists obviously occurs following a relationship breakdown. It can take place under 2 timescales. The first is an 8-day timescale, and that usually follows what's called an irretrievable breakdown of the relationship between the patient and the practice. It's usually initiated by the practice, but they would normally warn the patient that this is going to take place. Patients who are removed on the 8-day removal can register at alternative practices with no prejudice whatsoever, and all their medical records are transferred to the new practice to enable appropriate care to continue. Removals that follow more serious incidents, so those that are reported to the police or those where there is violence or staff or other patients are in fear of their safety, patients can be removed immediately from the practice. That's something that practices take very, very seriously and do not do lightly. But it is incumbent upon us as an ICB to ensure that there is ongoing care for those patients. And so we commission a special allocation scheme, which essentially is a practice where patients who have been removed for reasons of violence or extreme unreasonable behaviour can be registered and can continue to receive ongoing general practice care in a safe environment. We commission 4 providers across Staffordshire and Stoke-on-Trent to allow for geographical cover, and the patient then remains on that scheme for a period of 12 months, at which point they are then reviewed to see if they can go back into mainstream practice.
Thank you, Lorna.
And finally, Baz asked if I would read out some positive comments. The first is around the ICB system quality meetings. Are appreciated for their good turnout and data sharing, and they are assured that the ICB are doing their best to involve all partners to get the best out of these meetings. Patient experience is being shared by Healthwatch, taken seriously by the ICB and NHS providers, and they can see actions being made to make these positive steps to improve patient experience. Healthwatch are invited to all appropriate meetings and kept informed on trends and themes by ICB colleagues. Data is shared 2 ways in a timely manner, improving trust and collaboration, and Health Watch reports are being used to inform how services are being shaped to improve patient experiences.
Tracy, thank you for that. And obviously, we'll thank Baz. He is due to attend the meeting with the National Chair this afternoon. Really great questions, but also some superb feedback there that gives Heather, I think, tremendous encouragement to actually continue to go further with that work in terms of, you know, the transparency and the adherence to the compact that we discussed at the start of the meeting. Heather?
Yeah, absolutely. Thank you, Chair. And I think just to underline the comment, really, the contribution that Health Watch play in terms of the system quality group is really, really valuable. So to be able to have that two-way relationship and to bring in that extra dimension in terms of all the angles of assurance really does serve to do exactly as Baz described, and I look forward to that continuing. So
Thanks, Heather. Okay, so Tracy, if that's all of the questions that we've had submitted in advance, we're going to move into a very important item now. The community story item 7, whooping cough vaccinations across Staffordshire and Stoke-on-Trent. Matthew, thank you very much for stepping in to cover this for us this afternoon. Can I hand straight over to you?
Yep, absolutely, more than happy to. For those who don't know me, my name is Matthew Misson. I'm a consultant in public health, and I have a joint role working across the Integrated Care Board and also University Hospitals of North Midlands, supporting public health agenda. So, today's a very important topic, and I'll just want to convey a few important messages. So, firstly, we are seeing increasing occurrence of vaccine preventable disease. People be aware of recent challenge around measles. The current situation that we face is an increasing occurrence of pertussis or whooping cough in our population. This can be severe for all patients, arguably, but there's a particular population group which is at increased complications, and that is pregnant women and newborn infants that are too young to have received the vaccine. So they are really our key population group that we are wanting to protect through this work. Nationally, regionally and locally, the past decade has sadly seen declining coverage of uptake of pertussis vaccination during pregnancy. And this is partly why we've found this situation where we are starting to see increasing pertussis is across the routine vaccination schedule. So there are the doses given later on. I think importantly, we have responded to this situation, and there's very much been a multi-element response to that. We've been working very closely with maternity system leads and key leads within our maternity services to look at how we can better promote the vaccine to expectant mothers and also address some of the barriers that are preventing mothers from participating and receiving the vaccine. As a result of that work and some of the communication and engagement work, which I'll share shortly, positively, we have seen an uptick in vaccination rate within the past 6 months. So we've increased by around 6%, up to 64.2% in our last monthly report for vaccination coverage. That said, there remains a significant inequalities challenge in that we are aware there are certain population groups within our geography with protected characteristics that are less likely to participate and receive the pertussis vaccination during pregnancy. And there's a multitude of reasons for that. I won't go into all of the detail, but there's some around vaccine hesitancy, concern around safety, and also not necessarily being clear on how to access and receive the vaccine. So we've been working very closely with communications and engagement colleagues to develop a suite of resources, look at media communications, information resources that can be almost conveyed to pregnant women and try and promote the vaccine that is available. And importantly, what has become clear from that is the group that pregnant women are most receptive to is our midwifery workforce. And reflective of this, we've produced a kind of suite of media resources which are looking to kind of make use of that. And there should hopefully be a video available just as an example of some of what we have produced in response to this. So I'll look to colleagues.
So Matthew, we'll play the video now, and the video I understand is for the public, so it'll be widely available to encourage people to uptake. Yeah,
This is it. And certainly thank you to Angela Hancock, who is our star midwife within the video, was a perhaps unwilling volunteer who stepped forward, but feedback received from pregnant women so far has indicated that this is something that is quite impactful, and the messaging contained within is received well.
okay. So we're going to see that now.
Pertussis, also known as whooping cough, is an infectious disease which spreads easily. Newborn babies don't yet have fully developed immune systems, so they are particularly vulnerable to infection. Babies who've not yet received their childhood vaccinations are at the highest risk if they catch whooping cough, and this could be serious complications, needing admission to hospital, and also a risk of dying. Babies will have the first whooping cough vaccine at 8 weeks of age. To protect them until they're old enough to be vaccinated, the whooping cough vaccine has been given to mothers during pregnancy in the UK since October 2012. This not only protects the mother from catching whooping cough and from serious disease, but antibodies are then passed from the mother to the baby, and this provides protection to the baby until they are vaccinated at 8 weeks of age. Mothers should be vaccinated in every pregnancy to get the best protection for themselves and their baby. We know that vaccination in pregnancy is 97% effective at preventing death in young babies from whooping cough. Mothers can receive the whooping cough vaccination from 16 weeks of pregnancy at some of their antenatal appointments and also at the GP surgery. It's most effective if it's given before 32 weeks of pregnancy. It's important to be vaccinated with every pregnancy, so each time you're pregnant you'll need a new whooping cough vaccination to protect the baby. Making sure that other children and family members are vaccinated will also help protect the mother and the baby. For more information about whooping cough vaccination, please visit the NHS website.
There's some simple messages in there, but what's been quite revealing is that some of that simple messaging actually addresses key issues in our population. So many women have not been aware of that need to have the vaccine during every pregnancy. There's some kind of perhaps a myth that once you've had that vaccination, that conveys immunity for life. So we've certainly managed to develop media resources, grounded in national evidence, but also informed by local engagement. So that's an example. I'm more than happy to take any questions around the current situation around pertussis, uptake of the vaccine, or work being undertaken in response.
Okay. Matthew, thanks very much for the presentation. Just wanted to ask, in terms of the resources that will be available on the website, presumably they will be in different languages, and it will be accessible to all of our community.
So that is what we're looking at the moment. As a starting point, we've certainly had them produced in English, but as absolutely, the point that you make is very important, and there is something around having them translated and made available in multilingual and accessible format.
Yeah. And if at all possible as well, having some feedback loops just to check how effective people from those communities have felt the materials were when they were released.
So that's certainly the plan. Next steps. We are fortunate in that we have quite a well-developed local maternity voices forum, and that provides a very good engagement platform to sense check what we're doing and engage with. There's always that question of representativeness, and importantly, where we have particular population groups that may not be represented within that forum. Certainly looking at how we can work with maternity leads like Angela to try and engage and develop insight to check what we're doing is kind of receptive and reflective of what people need.
So just in terms of the recommendation that we'll come to in a moment, if we could just make sure those issues are accelerated as this goes live, so that everybody has access to this very important information. Shokat.
Chair, thank you. My question is really, Matthew, linked to what David has just been speaking about, and great presentation and a good video as well. And I was in particular thinking of where mothers where English is not their first language, they may be new to the country, at times very culturally unaware, and that sort of stigma about vaccinations, and what maybe other family members are telling them about not having a vaccination. So I think it just needs to be a little bit more than having something in other languages. It's what other channels and how we can be a bit more innovative in how we get that message and that sort of more direct conversation.
Yeah, thanks, Showkat. Great question.
So this is very important and a key part of any approach to addressing health inequalities. We are very aware that levels of literacy and the appropriate almost communication channels will vary depending on which group of kind of part of the population you are, and some may not be that receptive to traditional media platforms that we would look to use. To address this, we are working closely with council, public health colleagues, and are looking to engage with BCSE sector colleagues in communities who are very well placed to make use of community channels and engage with these groups that may not necessarily engage with other forums that we've more traditionally used. So there are plans in place so that we haven't yet started that work, but now that we have the media resources developed, that is our big next step in this project.
Okay, thank you. Tracy?
Yeah, just following on from that, we learned a lot through the COVID vaccination and how we had to deliver the vaccinations to different areas, you know, and we learned through fruit farmers, we were going out there, you know, there's all sorts of different things that we've done. So we need to apply the same sort of methodology and actually understand who is the trusted voice in this. And I think Matthew said the midwife is very much a trusted voice in that. So, you know, we need to help support them so they've got, you know, the right messaging to the right public. But we've learned a lot through vaccinations on how we can actually reach those communities, and it's not one size fits all, and I think that's the important thing that we need to do with all our engagement and involvement work.
Okay, thanks, Tracy. Mish?
Thank you. I'll let Heather come in. Sorry, Heather. We do a lot of work in schools in the people function, and my experience of working to the harder to reach communities is that quite often the older children in the family are quite a good route into the wider family and the wider community, especially with some of the digital tools that you have. If you want to pass them to my team, we can disseminate them to a place like Stoke College, for example, and therefore hopefully get the message through that way as well.
Thank you.
Thanks, Mish. Heather?
I just wanted to add really, and Matthew will know this because of the work that happens between maternity and the work that Matthew's describing, but just wanted to reassure everybody, and particularly given Showkat's question, that the local maternity and neonatal service, I nearly used an abbreviation then, affectionately known as the LMNS, do have an equity and equality strategy which is being implemented. And it's absolutely about targeting exactly the groups that you talked about there, Showkat. So, you know, it's not a separate piece of work, it's running in parallel, but it's absolutely about linking up and making sure we exploit every opportunity we can to do things differently to ensure we target these hard to reach groups.
Okay, thanks, Heather. Bas?
Just quickly comment on that. I just think it's really important, and I did like the video as well. And just thinking about some of those communities and how you're going to tie in with the VCSE sector, because it's quite a lot of elements of VCSE that are already working with those communities, and they've already built that rapport up and that trust up. So rather than just starting again, and it could be challenging, there might be some of those routes in as well.
Yes, that's it. For me, it's very much making use of existing channels that we can better use to reach the target groups. I think the other point, just to emphasise the point that Tracy makes, is very important with evidence-based, that even in some of these groups that experience health inequalities, and actually the role of the midwife and our midwifery teams is very important, and it is that promotion from midwives is something that actually the population as a whole is very receptive to when women are going through pregnancy. So that's a key vehicle within which we are pushing at the moment with our maternity services, but there is work that can be done within communities as well.
Okay, thank you, Matthew. So today we're given the opportunity to showcase the work and the work that's going on to actually really drive this through communities. So thank you for bringing the video and the presentation along, Matthew. If we could also accelerate the issues that we've described, and particularly Shokat's summary of that, as we move forward. And Heather, I'm just looking over at you. I'm presuming that this will be, the take-up will be monitored through quality and safety and come back.
Well, yeah, it will, through the links that we have through the LMNS and Matthew's team. So yes, is the short answer there.
And the other point, Baz's point about the VCSE sector as well, if we can just make sure that they are universally engaged with this as well, because obviously they have a tremendous role to play in terms of the linkage into those communities. Okay, so if everybody's happy with that, Matthew, thanks very much. I know you've stepped in at very short notice today to cover this, so thank you very much. Appreciate it. Thank you. Okay, so we move into the Chair and Chief Executive report, and I've got a few introductions to make in a moment, but I just wanted to pick out a few things first from the report, and then I'll hand over to Peter. You'll note in there that there is a piece around the undertakings with NHSE. I'll hand over to Peter in a moment to talk about some of that linked to the financial pressure that the system is facing. Secondly, I just wanted under 1.2, Mish and Gemma, I just wanted to acknowledge that you were stars at the NHS Confederation Expo. So it was great to see Staffordshire and Stoke-on-Trent integrated care system actually paraded there. So well done on that. I also just want to make a point of congratulating VAST. I went out to visit VAST last week and met with Lisa Healings at the Dudson Centre, and yesterday heard that VAST have been awarded a local infrastructure quality accreditation award by NAVCA. And when you look at the work involved in actually getting that accreditation, it's a really tremendous achievement. So I just wanted to say a really warm congratulations to colleagues at VAST for pulling that off. Thirdly, I'm delighted to welcome Tony Arm to the board. Tony, welcome. Tony is a prominent dentist in Staffordshire, a fellow of the Royal College, and also the chair of Staffordshire and Stoke-on-Trent Dental Network, and you've done that for over 10 years. The board has been really keen to ramp up the expertise that we've got around dental care. This has been a pressure that's come through from MPs, our own work to actually tackle inequalities, and your appointment has been widely welcomed by colleagues in Stoke and Staffordshire to be able to tackle some of those issues that we're grappling with on dentistry. So Tony, a really warm welcome, and I hope you enjoy the next 6 months or so as a co-opted member onto the board.
Thank you. Can't wait.
And last, without further ado, I just wanted to welcome David Crossdale Appleby, who's joining Baz today. David's the National Chair of Health Watch England. And David, just reading through some of the things that you've done over your career, it really is a very impressive CV with all of the areas that you're involved in: academic medical research educationalist, and also chair of the Royal College of Physicians, and chairs Durham University International Business School and Dementia UK. And I was really intrigued that in 2016 you were national non-executive of the year. So some tremendous
very little competition there.
So perhaps we should be asking you to run a masterclass today, but it's great that you've taken the opportunity to visit Stoke and Staffordshire today. Both Simon Fogel in Stoke and the work that Baz is doing more broadly is really valuable, welcomed and embedded in what we are trying to do here. So I'm just going to give you a couple of minutes, David, on our busy agenda, if you'd like to just say a few words about the national work and the linkage with the locality.
Do you mean literally 2 minutes?
2 minutes.
Right. Okay. Right. Well, I suppose, firstly, thank you very much for those kind words and how nice to meet you all. This is where, of course, Health Watch started, Staffordshire, after the mid-staff scandal, etc. So kind of coming home in a way. Just giving you the highlights of what I wanted to say. What do people really tell us that they want? First and foremost, they want to see accessible, affordable social care. And I can remember, and you will remember, the Dilnot report of 2011 that was produced. And I, with a colleague, also did a major input to that. And that was based on some work that I did internationally, looking at where integrated care had a proven track record of working. And I came to the conclusion that 4 things were necessary if we were really to get something in social care. And those were, there had to be a personal contribution. There had to be a contribution from central taxation. There had to be a creation of what are termed mutuals. Those are organizations set up in order to provide funding. And finally, there had to be an insurance component. Without those, no country has managed to get an effective and sustainable national social care thing. So these were points that I've just remade to Wes Streeting since, well, actually, before his appointment, on the basis that we could fairly well predict what was going to happen in the election. In terms of the NHS, what do we need? And we've, at Health Watch, produced our vision for 2030 on that. And we recognise that there are really well thought through recovery plans for primary care, urgent and emergency care, maternity, we've just seen the presentation, dentistry, your presence here. But what seems to be lacking is that those plans are not really being put into effect. The plans are there, they're not being into effect. I mean, an example really is pharmacies. You know, we say pharmacies could be a key answer to expanding the capability of the primary care sector. But I did a piece of back of the fag packet calculation about what the business model of a pharmacy is. And I looked at, you know, the Boots and the Lloyds, and I looked at the mama papa shops, which a lot are. And you see when you look at that they are so dependent on being able to continue to prescribe on the retail sales they make of creams and all those other things, etc. So if you want to bring pharmacies in, you've got to understand their business model and you've got to allow that to work. And that hasn't been done so far. And what do we see? We see pharmacies closing left, right, and centre, both some of the big chains and some of the smaller ones. So I just want to finish then on three points, which are about the NHS. We need to make the NHS easier to access and easier to navigate. Everybody in this room, including the guests behind, will know how to navigate the system. But the people that I spend my life with, they don't know how to navigate the system. They don't know what a system is. They don't know how to get into it. They don't know what it could do or what it can't do. The second thing is to tackle health inequalities. And you know this, Peter, very well, that when we set up the ICS, when I did the work on looking around the world at different ICS systems and which actually worked, the reason that we chose the Alzira system in Spain was because it was the one that seemed best for our country and our culture. But one of the two overarching objectives that we have here, and also they had in the Alzira system in Spain, was the health of the population, the health and well-being of the population. And the second thing was reducing health inequalities. What have we actually seen? We see, for various reasons, the health inequality disparities actually increasing rather than decreasing. Austerity. And so many of these are linked causatively, not just statistically, with deprivation and poverty. And, you know, we have to encompass that understanding in what we do. But the third area, third of the three, is that we have to build a more patient-centered culture in the NHS, because, you know, the NHS created 76 years ago wasn't created for the benefit of provider organisations. It was provided for the benefit of our people and our society. It was the thing that was going to hold our society together. And yet today, 30% of women state to Health Watch, you know, that they don't have confidence in being listened to by the healthcare professional. And this just shows the degree to which, you know, the NHS has been allowed to slip into the situation that you face every day about, you mentioned, you know, financial stringencies, etc. So what we need there is to change the balance, to embed a much more central viewpoint and voice of the patient, the carer, and the public. And my final point really is about the independence of the 153 networked health watchers. They are set up to be independent. They are there to speak truth to power, and that's really important. They must be independent. And I suppose my final point is just to bring you right up to date with what's happening. I shared this narrative, although 5 pages of it, recently with both Wes Streeting and also with our newly appointed minister, which some of you will know, Baroness Gillian Merrim. You may know, those of us who go back to the Tony Blair era will remember Gillian. I mean, it's very difficult to forget Gillian. Highly intelligent, highly provocative in a way. And when I heard that she was going to be our minister, I can't tell you how absolutely delighted I was. Okay, she's in the House of Lords, not the House of Commons, but she'll overcome that, I'm quite sure. But she said to me when we were talking, she said, I can't tell you, David, I am so delighted at the portfolio that I've been managed to negotiate. She said, it's patient safety, it's women's health and mental health. And what could be, you know, kind of higher up the ICB list of priorities, and certainly Baz right up high in our priorities for the network, are those 3 things. So I'm absolutely delighted, firstly, to be here today and share these things with you. And I'm incredibly optimistic about the future. So thank you for the invitation. Thank you very much. I hope I've stuck to the 2 minutes.
Yeah. Thank you very much, David, for doing that. And you know, once again, it's great to see you on the patch.
That's very
and, you know, it'd be great to have that regular communication through our local health watches to understand the work nationally as well in greater detail. So thanks for taking the time, and hope you're having a really good tour around the patch as well with Vaz.
Certainly am.
During the course of today. So warm welcome to you. Peter, can I hand over to you?
Oh,
Pick up any other
how'd you follow that? I mean, come on. Right, but yeah, try. A big thank you, actually, really helpful. And I will talk about a few other things, but actually just listening to that, I was reflecting on a place session that we had yesterday, our Stoke-on-Trent place session, and a huge amount of what you've described came through. The challenge, I think, or the issue that we've got right now that we are addressing is that we're not moving as quick as we need to on the inequalities agenda through place. So as much as inequalities at a system level, absolutely, we've got the opportunity to address issues through PHM and other things. The place route through to neighbourhoods, localities, you name it, but that localised approach to things, for me, is fundamental to success. And I am really conscious that we haven't been doing enough of that in Staffordshire over the last couple of years. And I could wax lyrical on the pressure nationally, the pressure locally that forces you into that in the moment way of thinking. But I won't go there. I'll say, actually, we should have been doing more. We can do more. And fundamentally, we will do more. Right. So thank you. That was a really, really impressive narrative. So just on to more mundane matters, I suppose it would be remiss of me not to talk about finance, and Paul will talk in a moment about it, but we do have a significant financial challenge that we are tackling, and I'm confident that the work that we're doing is addressing it directly. But it's also fair to say that the scale of the ask that we have this year, circa £200 million savings programme, is very, very significant and unprecedented in terms of Staffordshire. What I would say in the same breath is that equal challenges, if not greater challenges, are being posed to every single system across the country, all 42 integrated care systems, and our national position is financially not good at all. So we aren't alone in this regard, is what I'd say. But I absolutely don't think that we should be defeatist in any way, shape or form, although the mountain is quite significant that we've got to climb. I think the work that we're doing is the right work. The other thing I would say is that what I would hate to think happens is that the financial challenges overshadow all of the great work that we're doing in Staffordshire. So that isn't to flip to the other side and try and sort of shove the financial issues under the carpet. Absolutely, we have to understand that. But I've just written a couple of things down that, you know, as I was going through the papers and sort of getting to grips with where we are, shone for me. So the elective recovery piece, the amount of work that we've done over the last, particularly 6 months, to break down that elective backlog is mammoth, absolutely mammoth. The vaccination programme, we talked about that a moment ago in terms of the work. I know we're really good at vaccination management in Staffordshire, but the last tranche has proved that, I think, in spadefuls. And finally, the LDA work that isn't very well signposted in the board report, but the inpatient numbers for LD&A are in the best place they've ever been, the best performance in the whole of the Midlands. And compared to where we were probably 5-6 years ago in the late teens, that's a remarkable performance. I think we're probably the worst in the region. So, you know, I'm not trying to, as I say, ignore the financial challenge. Clearly, that's front and centre. We've got to address it. But I just want us to not forget all of the great work that we are doing right the way across Staffordshire and Stoke-on-Trent.
Thanks very much, Peter. Just pause there if there are any questions. And just while we're doing that, I just wanted to say, because my notes are written a bit hiddly-piddly here, Helen, I just wanted to welcome you as well as Acting Chief Executive for University. An old friend to the board, Helen, but great to have you join us today. Okay, so if everybody's happy to receive the Chair and Chief Exec report, we'll do that. There's an opportunity as we go through the agenda this afternoon to drill down in detail in many of the things that are in the report and Peter's referred to. Okay, so if we could turn to item 9, please, transforming mental health inpatient services in Staffordshire and Stoke-on-Trent. And I think we're going to be joined on line by Nikki Bromwich, Upcar-Jeter and Laura Smith. Is that correct? Welcome.
Nikki.
Yeah, should I just say, apologies, Chair, Nikki can't be with us this afternoon, not morning, is it? So I can kind of introduce the paper and then I'll ask Laura and Upcar to take us through some of the detail.
Okay, thanks, Nikki. Over to you.
Great, thanks. What you have in front of you today is a transforming mental health inpatient services strategy, and it's here for approval and your support. This piece of work has been developed in collaboration with all system partners and key stakeholders through our mental health and learning disability autism portfolio. What I'm going to do is hand you over to Nikki and Upcar to just take us through some of the key headlines, really, and then obviously open it up to any questions. Thank you. Okay.
Thank you. Thanks. Hi, everybody. I'm Laura Smith. I'm Deputy Chief Strategy Officer at North Staffs Combined. I'll just provide some brief context around the strategy, and then Upcar and myself are happy to take any questions or comments. So the strategy that's been shared with you is one that we've developed in response to an NHSE requirement for all ICBs to publish a 3-year plan for transforming adult mental health inpatient care. As part of that programme, the mandated areas of service provision were acute inpatient services for adults and older adults, adult mental health rehabilitation inpatient services, and adult mental health inpatient services specifically for autistic adults and adults with a learning disability. As a system, we also made the decision at the outset to include dementia services within the scope of our programme. So that's something that you'll see within the strategy as well. Just to highlight the key areas of focus for the strategy in terms of those overarching headings is around preventing avoidable admissions, ensuring admissions are purposeful and that they deliver a clear therapeutic benefit, that we've got improved discharge planning and community support, that we're delivering further reductions in our use of out-of-area placements. And there's also a really strong emphasis on health inequality that we've sort of really tried to promote as part of our approach. So as was stated, the strategy has been developed through collaboration. We submitted an overview of our approach to NHSE in March, and we've used the feedback from that to really shape the structure and content of the final document. We have emphasised and want to emphasise it is a dynamic strategy. We've acknowledged the need that we need to do more analysis and partner engagement during this first year to shape the subsequent years of the programme. And that includes work across the system with our VCSE partners, particularly with housing providers, as accommodation is a key theme within the strategy, and also obviously local authorities, but it is a real true system piece of work. Important, I think, just to note that we did have a series of public engagement sessions that were scheduled to take place in June to inform this. Unfortunately, on the advice of NHS England, we did have to cancel those due to the pre-election period, but we are rescheduling those to run in the autumn so that we will have that engagement to shape the strategy going forward. And probably the final thing I just want to say is that I think it's important to reflect that in developing the strategy, whilst we did identify, a number of areas where we can go further in our improvements, there was also a lot we found in terms of, areas to celebrate and things that we're doing well, where we've made good progress. So for us, it's very much about how we use that learning and build on the success and continue that collaborative approach to deliver over the next 3 years. But I'll pause there, and Upcar and myself happy to take any questions or comments. Thank you.
Okay.
Thanks, Laura.
Thanks very much, Laura, for that. We'll take some comments then if we can. Laura, can I just ask a couple before I throw it open? Just on page 29, which I think has got the geared slide on it with the partners. I just wondered about the relationship with the police. You mentioned housing, which is not on there, but particularly around section 136 and impact on inpatient admissions. I just wondered if the police were engaged in the project and part of the team that's meeting. And also I noted Keele University were on there, but not Staffordshire. So if you could just clarify that for me, that would be great. And then I'll open it up for any wider questions.
Shall I take the first part, which kind of links into the work that we're doing with the police? So as partners may be aware that there's a whole programme of work around right care, right person, which is absolutely kind of linked to this piece of work. There's a really strong emphasis on utilisation of crisis alternatives. So we want to kind of maximise the use of those alternatives to inpatient and making sure that there's the least restrictive setting for our service users. So there is quite a lot of work going on with the police already, which is linked in with the inpatient transformation programme.
Okay, thanks, Upcar. I just wonder if it would strengthen the document if that was just made clearer on the diagram just on page 29. Any other questions or comments from members of the board? Megan?
Thank you. I really like the strategy. It's so full of really interesting data. One of the things that really concerned me was the mortality rates in people with a serious mental illness. Particularly driven by, it says here, high rates of cancer mortality. And it made me reflect in particular that we very much monitor at a system level the percentage of physical health checks which take place, but not about the quality of those health checks and not about all the other things that actually go into ensuring that people are healthy. So I was just wondering how much you know about the reasons behind those high mortality rates in the system.
And you're absolutely right, Megan. So carrying out kind of the physical health checks is one component of the process. It's what we do as a consequence of those checks. And that's what we need to kind of focus on is the so what. So are we following up on those service users where we've identified an issue and making sure that those follow-up actions are taking place? And there is a whole kind of section within our strategy which focuses on the population health needs associated with our kind of local population. There's lots of work to be done. We've identified a number of areas that we want to kind of focus on, which hopefully the strategy will give us a mechanism to try and make some headway with.
I would just add to that as well in terms of the focus that we've got within therapeutic care and therapeutic intervention. So that is meant in its broadest sense as well, whereby physical health is part of that. So again, looking to strengthen, the quality of what we do and that across the patient journey. So into the discharge planning and post-discharge support. So physical health will be a key component of that as well.
Thank you. Okay.
Yeah, thank you. I was just going to add to that, Megan, that this is one aspect of a wider kind of issue with regards to mental health. As we always say, there's no health without mental health, and it's features in a number of areas. So this is inpatient, but actually there's a wider community work and partnership with our GP colleagues, primary care. So you are absolutely right. There's so many things, lifestyle choices that we just need to support the general public with, as well as people who come in contact with our services.
Thanks,
And just on that point, Becky, because I think when we're considering the public engagement sessions, we'll be looking at the whole spectrum of mental health services and taking the opportunities to make sure that we engage on how can we improve the entire spectrum of services at the same time. It's really difficult when you do public engagement sessions just to focus on one aspect.
Thanks, Bucky. Shokal?
Yeah, Chair, it was I really like the way the strategy has been set out, and I particularly like the bit around the lived experiences piece and about valuing lived experiences. So there was an element around there about the workforce and the engagement with the workforce, but alongside that, I think it's important. I think some of the reference to the lived experiences was about the service users and how we engage with them. But I think the workforce is quite critical to that as well, in terms of people who may have the lived experience, or certainly through family members, and recognising how big the NHS workforce is. I think that bit is important. The only other point I want to make was around accessibility, because we know the range of challenges that exist in accessibility and across different agencies as well. So, you may get a sense of frustration either from the police or from the local authority around the whole piece around accessibility. So I think it'll be important from a monitoring point of view in terms of what's being set out, that we've really got a temperature check on what our targets are around accessibility and where we are. And then just a final point, Leader, what Chair, is quite startling in terms of the number of detentions per 100,000 in terms of Black people, and it's a frightening statistic, isn't it, in terms of what's presented there?
Yeah, you're right to pick that out, as Megan was right to pick it out. Stark, isn't it? That's statistic. Okay, can I just check? Everybody, Helen, did you have your hand up? No. Everybody had an opportunity to ask questions on this important document. Okay, so what I'd like to do then is, if we can endorse the strategy as being recommended, it's been through quality and safety. I guess the only thing I would suggest, to Bucky's point, whether just at the start, whether the linkage with the wider strategies might just help. That this docks into a much bigger piece of work that's ongoing. And just picking up the helpful points that have been made by colleagues around the table in terms of some of the detail. But thank you very much on behalf of the board for the work you're undertaking.
Thank you.
Thanks.
Okay, thank you very much for that. Paul, we'll move straight into item 10 if we can, building a system medium-term plan.
Thank you, Dave. Recognise there's only 5 minutes to this item, so I'm going to just limit myself to just 3 quick points. For me, the first is to build on what Peter said at the start, really, which is we're determined to make sure that finance doesn't define us. We need to get the finances sorted out, because until we do, we can't deliver the care that we want to. But it can't be defined, but our future can't be defined by finance, and that's why this is such an important piece of work that we are undertaking. The work has been through the Finance and Performance Committee already, David. So as I say, I'll just be brief in 2 other points. One is just to point you to the timeline. I think what we're aiming to do here is establish clarity, evidence built up with colleagues across the system, and then be able to have a conversation with regulators about the time that we need to return the system to financial balance. We're sure we can do it. It's the timeline that's the key thing, and having that agreed up front is going to be really, really important, because the planning round this time was really difficult for everybody. Trying to agree a number even after the year had started, it's just no way to go forward. So next year we're determined to have those conversations with regulators early in the run up to Christmas. So we've got clarity on a 3-year 4-year, 5-year horizon, so that we can then go into a planning period after Christmas that is built on a understanding of what we need to deliver. And then the other point is just to highlight the strategy that we're adopting. It's on page 117 pack, the bundle, which hopefully just illustrates what I said at the start, really, which is that this plan is not about finance. Finance falls out the back of it. What we're doing is building with our clinicians a clinical model, and that will determine the activities that we need to provide to our population. Working on the workforce. Workforce is where we spend most of our money. That's where our talents are, and then bring that together using digital to drive better productivity, and then the money falls out of the back of that. That's the process we're going through, David. Fully signed up to now by system colleagues. Work is already underway. You've seen the milestones, and we'll keep the board updated as we go.
Okay, thank you very much, Paul. Any points of clarification for Paul? I think, Paul, it's just worth saying that one system, one plan, it's very evident in the next piece as well, that all system partners have taken the next plan through their governance routes. On Monday of this week, we had what I thought was a very successful discussion with NHS colleagues, with chairs, chief executives, chief medical finance officers, and people from the Senate and Assembly, where we did get to a point of how we are going to tackle this, but also just keep a watching eye on the impact on quality and safety as we're undertaking that, which has to be paramount. Neil?
Thanks very much, David. I agree entirely with what Paul's saying. You've heard an example of where mental health is at, but physical healthcare could make the same presentation, whether it be in the acute or the community section. I think we need to recognise the amount of research, development, innovation that's taking place in those areas. And I think the sooner the better we can move into what I would call the transformation piece and start talking about invest to save, because we've got a workforce out there that are committed to being financially effective and efficient, but also changing for the better clinical services. And I think when we can give them confidence, we're able to respond to that. It will serve us well as a system, and certainly the people we serve.
Yeah, thanks, Nick. Okay, so if there's no further questions on that, we'll note the medium-term plan has been approved by the Finance and Performance Committee, so we're ratifying that agreement today. It's being presented today for information and assurance, and there'll be a lot more to say and review on this, Paul, in the months ahead. Okay, so Paul, we'll move into item 11 then, if we can, the system operational plan.
Thank you. A piece of work that's been co-produced across the system over several months. We've had over the past year several system meetings where we've come together, and all the ideas in the plan are ideas that have been developed across the system collaboratively. Slide 125, the pack, shows that we built this 1-year plan from strategy, the 5 Ps as we call it, through the joint forward plan, and through that created the priorities for the current year. 2 overriding aims you've seen covered on page 131 of the pack. So the overriding key aim 1 is safe, timely, sustainable care. Aim 2 is meeting the capacity challenges that we have. Those run through everything that we've done. And then we've agreed 5 areas of priority. You can see them, I'll read through them, but you can see the areas of priority that have emerged through the system conversations that we've had. The plan shows how those objectives have been delivered through the portfolios. Those portfolio work is Helen's here from UHM, worked with strategy colleagues to ensure that trust plans connect to this, and it's a joint effort so that we've got clarity here in terms of who's doing what across the portfolios and with providers. Within the plan, we've also covered the recovery plan, which, David, we've talked about here before, haven't we? The 5 areas of recovery are defined, and again, hopefully you can see that that is integrated into the plan. So we've got one plan delivering all the key objectives, all the required business as usual, and the recovery items, which collectively come together to deliver safe care meet our operational clinical challenges, and also achieve the financial target, which, as you know, is not a financial break-even target this year, but a deficit target of 90 million. David, you mentioned the meeting on Monday. I agree, it was really positive to have all chairs of trusts and F&P committees, CEOs together, and collective commitment to delivering this plan and delivering a deficit of 90 million, which might sound a bit odd saying that would be a success, but it would be a success given that we came into the year with projection of much higher than that. So I think coming together to deliver that 90 million and all those operational targets, it's going to be tough, but it's something we're all committed to. I'll probably stop there to allow time for some conversation.
Thank you very much, Paul. Comments for Paul? Peter? No. Okay. Megan?
Just to say that it's obviously a huge amount of work's taking place to get this operational plan to where it is. I think it's a step forward from where we were last year. I think the fact that we worked very closely with providers across the system, been through all provider boards already, and the Finance Performance Committee, it's ICB level, we kept very busy monitoring our performance against it going forward.
Okay, thanks, Megan. I'm just aware from members of the public at the back and our guests that the acoustics might not be pretty good in here.
Windows are open. The sound isn't very good.
Yeah. So colleagues, we might just need to raise the volume of our voices a bit. Ian, can you hear?
I can hear you.
You can hear me. Yeah,
I can also hear you, David.
Yes. Yeah, I know. I could just tell from the non-verbals you were giving me, and that you were unable to hear. So
I'll project further. Sorry.
We'll try and up the volume. And just in response to Megan was talking about the collective response to this, and I think for many of us around the table, who've seen plans on a year-by-year basis, we are really getting to the point where it is one system, one plan, and the effort behind that and energy that's going into it. That's why I made reference to the meeting on Monday. There really is a sense of common purpose that we're in this together to actually, get out of the situation we're in, so we can really concentrate on the very important stuff that we had a timely reminder from David on, in terms of the inequality piece and the outcomes for patients. So if everybody is happy to approve the 24-25 system operational plan, all no pressure, it's now get on and deliver it, I suppose, is the outcome of that. So we'll approve that, and thank you very much to everybody involved for the work involved. Okay, Pauline, welcome. Can I ask you to take us through item 12, the development programme for the board? Another very important paper in terms of the development and maturation of the board.
Thank you, Chair. Good afternoon, everybody. I'm Pauline Grant. I'm the Associate Director for overly at combined and also across the system. What you have in front of you is a proposal for a programme of board development, and it's coming for information and approval today. Really like to stress it's very much an evolving programme at the moment. What you see in the paper today are things that have come out of some of the board development conversations that we've had to date, some of the board governance reviews, and some of the issues that members have highlighted that they would like to address. And we've used those to start forming the content of the programme. And that will evolve over the next 18 months. We have a focus on psychological safety. That's come out of something really, really important. We're also seeing that coming out in discussions around with some of our provider organisations. So you'll be aware we're developing our system OD plan. And again, similar themes that are coming out of some of our board discussions are coming out of some of the conversations that I'm having with partner organisations. So I think really, really important to think about how we use the programme to develop effectiveness as a board, but also thinking about how we take those things forward in how we lead across our organisations. It's a couple of items for approval. The board talked about having these sessions taking place away from these formal board days, face-to-face sessions where the board could get together more informally to discuss some of these issues and address some of the points we've raised here, very much within the context of the issues that Paul's talked about, but thinking about how we can align the programme to addressing those issues. So what we've proposed is to have 3 half-day sessions a year, so 6 in total over the next 18 months. So I'm seeking approval for that, the half-day sessions, and also approval towards just building on the diagnostic work that we've been doing, having interviews with board members, with other stakeholder colleagues as well, so that we can continue to inform the plan, inform the approach, and then really pin down what the future sessions will look like going forwards.
Thanks very much, Pauline. Very clear. And, thank you for your work on this as well. This is a really important piece of work to enable us to actually get under the skin of many of the issues that we're discussing today. So just pause there. I'm assuming Pauline's taken us through a bit of this process previously, and I know this has been pretty well socialised, but just looking around the room, everybody happy to commit to the recommendations, and we'll push that forward. In the afternoon session of the board today, we're fortunate that we've got a national speaker coming in to help us on that journey with psychological safety, a concept which is gaining momentum and certainly inspired me at the NHS Confederation Expo when I wandered into a few presentations on this subject. It's fundamental to what we're trying to do. So if the board are content, we've been asked to support the recommendations to further design and deliver a robust programme for Stoke-on-Trent and Staffordshire ICB board development by committing to take part in further diagnostic phases to fully develop the board development programme, and committing to take part in the further diagnostic phase, to take part in the board development activities by attending the 3 half-day face-to-face sessions each year, a total of 6 over the next 18 months. So if everybody's happy to agree to that, thank you. Pauline, thank you for that. Heather, we'll move straight into item 13, if we can, please, the quality and safety report.
Thank you, Chair. And just before I start on the briefing, one of the asks on the cover sheet is that we ratify the strategy that we were referring to earlier. So I was trying to catch your eye to say, can we do the two together? So by the fact that we've approved it as a board, I take it that we've ratified that decision made by the Quality Committee. I didn't want to miss that as I
know you'll always remind me, Heather.
I know, thank you. Apologies. And other than that, there was just one thing I particularly wanted to draw out, and that's in relation to quality and safety of services, but particularly in relation to urgent and emergency care. Phil and I are doing some work at the moment. So all boards have been asked to assure themselves that they're working with system partners to ensure that quality and safety remains central to the work that we're doing around urgent and emergency care, particularly in relation to working together to provide alternatives to ED, both attendance and admission from, and to ensure that we're supporting the maximisation of flow. So in addition to routine quality and safety oversight and assurance, and there's a lot of work we do, including visiting programme analysis of data and information and patient feedback, my team and Phil's team, from an urgent care point of view, are working together to make sure that we can accurately respond to that question in terms of assurance. And we will be pulling a paper together that we'll bring back here in the not too distant future. Colleagues may remember that not so long ago, we did a joint paper talking about some serious incidents from an urgent and emergency care point of view, and that was very well received by the board in terms of the angle that assured from. So we're going to take a similar approach to that and bring a response to that ask on behalf of the full system through to a future meeting. Other than that, and bringing that to everybody's attention, there wasn't anything I particularly wanted to draw out of the report, and I'm happy to take more questions.
Okay, thank you, Heather. Full report. Any points of clarification on Heather's report?
Yeah.
Phil?
Thank you. Just to add to said, that whole system approach is really important because we know that just under 60% of our population flow to University Hospital North Midlands emergency departments, and we've got significant flows elsewhere. So that piece of work that we're doing needs to look at a whole population focus, just to clarify that. Thank you.
Thanks, Phil. Okay, thank you. Okay, so we're being asked to receive the report and seek clarification. Further action is appropriate. Be assured in relation to the key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system, and to ratify the decision of the Quality and Safety Committee with regards to the ICS transforming mental health inpatient services in Staffordshire and Stoke-on-Trent. That just confirms that. Thank you, Heather.
Thank you.
Okay, so Lorna, next report, item 14, very welcome report actually, and the first one I think we've had in this format to the board. So can I hand over to you?
And indeed, Chair, and I present this on behalf of my colleague, the Chair of the Health and Care Senate, Rachel Gallio. I will take the paper as read, but the board are asked to ratify the approvals made by the Senate at the meeting in June. Those were that there were 5 NICE technology appraisals, drugs considered by our Integrated Medicines Optimisation Group. All of them are secondary care drugs. 4 out of the 5 relate to the treatment of various cancers. They were classified as red drugs, so they will be prescribed in secondary care and added to the formulary. We further harmonised our 2 Staffordshire and Stoke-on-Trent formularies. So the sections relating to drugs used to treat for headache, migraine, HIV, hepatitis C, respiratory syncytial virus infection and ENT conditions. We also ratified a single effective shared care agreement that will be used to care for patients who are receiving treatment with lithium. So that replaces 2 slightly different agreements that we had for patients who were being cared for by MPFT versus North Staffs Combined Healthcare Trust. So we now have 1 standard ESCA, which was ratified. And the final approval was that we will introduce a new designation to our formulary. We used to have 3 broad designations: red, anyone can prescribe; amber, should be initiated in secondary care or with secondary care advice; red, secondary care only. We've now introduced a new formulary designation, which is blue, and this was to cover any interim situation where the ICS is mandated to implement a NICE technology appraisal that has either a 30 or 90-day statutory implementation period. Obviously, within that, there needs to be local assessment of the commissioning arrangements for that, the provision, and various other elements of support to it. So the formulary designation blue allows us to add the drug to the formulary while we further determine the robust governance arrangements for that. So the board are asked to ratify those approvals, and I don't think that there's anything else particularly that we need to draw out from this month's meeting.
Lorna, thank you. And I'm sure the board will agree, actually, reading this report after Heather's report, I thought gave quite a really full picture of the work that's going on across the piece. And, you know, I thought it was really interesting to see the work of the Senate actually laid out in terms of what was actually happening in that space, Lorna. So, you know, welcome this and welcome future reports as well going forward. Is there any clarification anybody's got for Lorna on anything that's contained within the report? If not, we'll do exactly what Lorna's asked us to do, and that's to note the contents and welcome it actually and ratify the approvals made at the Staffordshire and Stoke-on-Trent and Health and Care Senate meeting held on the 13th of July. Okay, thanks, Lorna, to you and Rachel for everything that's going on there. Okay, so Paul, we're back in the finance domain at item 15.
Yeah, it's it's more widely actually. Yes. So if I could just quickly say a few words about the format, a few words if I may on the financial position, and hand to Phil to talk about the performance issues. So the format we've structured in line with the operating plan that we've just agreed to focus in on the key objectives that we signed off in that operating plan, and also to show how those cut across portfolios, so you can see quite clearly, hopefully, how all that comes together. And the request of the Finance and Performance Committee is that we pull out exceptions, which we've done in the report for your information, and you can see in Megan's report how those were considered in the committee afterwards. So the format is a draft. We're looking for feedback from people, not necessarily now, David, but outside, and we're we'll tie that up over the next few weeks and then produce that for next month. So that's the format. The second thing, as I said, is the current financial position. So it's early days, it's month 2, a bit too early to be sure about trends, but we do see signs of some financial tension in the system. We expected that, to be honest, because we, as you all know, agreed to a budget with a significant amount of stretch that was agreed actually after the financial year started. So we knew that it was going to be tricky at the start, and we are seeing some overspends. At the moment, 4.5 million, 0.6%. So we're still not in a position where we're saying that we can't do it. We can do it, but there's a long way to go, and there's some significant work to do to get there. Again, the meeting you referred to, David, on Monday, really pleased with that. And the system is absolutely up for doing everything that we can to achieve the number. So we're on it, but a lot of pressure to manage to get there. So I'll probably stop there, Chair. First take questions on finance. If there aren't any, then we go to performance.
Might not be any more in terms of the reports we've had already, Paul. Any points for Paul on the money? No. Okay. So Phil, hand over to you.
Yeah,
and
thank you.
Take over the performance side,
I'll
please.
just draw out a couple of exceptions. So firstly, in terms of urgent and emergency care, we're still in a very challenged place. We have seen improvement in some of our key performance indicators, so the 4-hour standard across our portals. We are over 70% and ahead of plan for the year. We've also, on a population level, seen improvement in the category 2 response times for ambulances. We're just under 31 minutes now against a 30-minute national standard. So that is far more positive than we were last year, when I think we were around 40 minutes on average. But as I say, we are still in a very challenged place with some significant spikes of demand. Recently, we've had rises in COVID and acuity, which have led to significant periods of difficulty, and critical incident was triggered at UH&M last week. We've got higher than we would want to as well in terms of hours of ambulances on the tarmac outside the hospital. So we know we've got to take action to improve that. Through the Finance Performance Committee, we're undertaking a piece of work to review all the periods of severe escalation, so all of the critical incidents we've had over the last 12 months to try and draw out learning and identify trends there. But our focus at the moment is very much on 3 things: on pathway, process and capacity. So pathway, we've got a new single point of access for care professionals going live in September, which MPUFT taking the lead on for us, which will help navigating people to the most appropriate care setting, which isn't necessarily an ED. From a process point of view, we've got a great deal of work going on to ensure that where ambulances are arriving at hospital, we're handing over swiftly, and that we've got good processes internally within ED and within our wards. And then from a capacity perspective, next month we'll see new capacity come online at the Royal Stoke Hospital. We've got 30 beds and a new same-day emergency care facility, which will significantly help with that front door capacity. And also, although it's a hot day, we're planning for winter at the moment, and we'll update in progress with that in the fall. Just from a planned care perspective, the key milestone that we're working towards is the meeting the 65-week wait challenge by the end of September. We know that is very difficult for us with the levels of patients we have on the waiting list. However, we have come a long way. I think, as Peter alluded to at the start of the meeting, this time last year, we had over 37,000 people waiting in excess of 65 weeks. We've now got around 1,600. So we've made massive progress in that space. We've also got significant extra capacity that has either been mobilised or in the process of being mobilised to support us to meet that September ambition. But that ambition is not without risk. So we'll keep the board updated in terms of progress there. From a diagnostics perspective, we've got a new temporary endoscopy unit going live at County Hospital at the beginning of August, and that will support us in terms of both surveillance patients and active waiters to ensure that we're seeing people in a timely way and improving our timeliness there. And then lastly, just around cancer, our cancer backlogs, the 62-day backlog is now in what we would call a sustainable position. That's halved over the last year, and we're seeing significant improvements around our delivery against the 62-day performance standard and the faster diagnosis standard for cancer as well. So I think that's positive story, definitely. Thank you.
Thanks very much, Phil. Phil, can you just ask on the report, the 104.78 week position, which is very small now.
Yeah.
But just seeking the assurance that that will be zero as predicted in the report by the timescales indicated.
Yeah, so certainly 104-week waits have proven a challenge for us, although the ones reported for June included some corneal transplant patients who came over from a different provider that we needed to support treating. 78-week waits, I think we're forecasting 7 at the end of July at the moment, and we're working to minimise those. The real challenge here is around data quality, which I've highlighted before. So this notion of pop-ups where patients are reappearing on a waiting list, but we are working through validation. I think by the end of this month, we'll have revalidated all of our patients waiting over 52 weeks to minimise the risk of any surprises there in terms of the data. And then we've also got enhanced programmes around training and education really for staff in terms of application of national RTT rules. So again, we're keeping updated through the Finance Performance Committee around that.
Just with the great work around 65 weeks, if we could switch those lights off,
yes,
you know, there'd be more focus on that.
Yeah, absolutely.
Thank you. Tracy?
I really like the report where it's all pulled together in the sort of dashboard because it talks to me. Seeing from our public, I recognise you said it earlier as well. I mean, it's covering the whole of Staffordshire and Stoke-on-Trent. That's a challenge and something that we're trying to get to moving forward, I take it.
Yes, yeah, absolutely. And we had a conversation at Overview and Scrutiny Committee yesterday around the same report as well, and ensuring that it displays the full sort of range in terms of services that the whole population access, but certainly the updates today that we've given reflect the whole population.
Thanks, Tracy. Thanks, Phil. Helen?
Just to point on UEC really and surge planning, I think it's a system we're very well versed in planning for winter. However, if you look at the last couple of weeks, the last 3 years, we had a surge over that period at each point. And so I do think we're getting better at understanding where we have surges outside of the winter period. We need to be able to respond to them because they're pretty predictable, even though we don't always realise that through our planning. So certainly if you look at the last 3 years, we've had significant demand increases over that June, July.
Okay. Thanks, Helen. Okay. So everybody happy to note the recommendations, high-level performance report against the 5 priorities, note the progress to date, high-level key programme deliverables, and note the financial situation in month 2, and note and take assurance on the next step in developing the performance and programmes for month 2. Okay, so if we could then, Megan, just take item 14 and closure 14, your report, please. Again, a very full report from the activity of the Finance and Performance Committee.
Thank you. I hope you can hear me a bit better down there.
Yes.
Yeah, just wanted to mention 2 things that have moved on and we've heard about here today. The first one is under the monthly finance report. My report talks about significant concern around the system financial position and a meeting to take place on the 15th of July to discuss what to do about it. That's the meeting you've heard about here today, which was very positive. Further actions were agreed. The second one is in relation to system efficiency plan and recovery programme update, where it mentions that we're behind in delivering detailed delivery plans, and a final deadline of 9th of July was set for getting all these together. They were all delivered and now being sent off to NHS England for their perusal. The only things I wanted to mention were just to note the potential impact that collective action in general practice could have across a range of priorities and performance measures, which we have across our operational plan and recovery programme. That was made very clear at the last committee meeting. In terms of performance, I just wanted to bring out learning disability and autism portfolio measure around the deteriorating position on children and young people in inpatient care within Staffordshire Stoke-on-Trent. So with a current position of 9 against a trajectory of 3, and that places us as the second worst position in the Midlands. Now, there's a lot of work which is taking place to address this. It is a challenge, there's no quick fix around it, but I do think it's important for us to remain aware of our position and the importance of moving forward on that. And then finally, I just wanted to raise again our situation in terms of capital. I mentioned this at my last report to board. We had a further report back to our July committee meeting around capital. It remains a significant risk for us in this year and going forward. And further work is taking place to try and mitigate those risks. At the moment, they are not mitigated, and we'll have a further report back in September to provide more information on that.
Thanks very much, Megan, for those two key items there that the board's noting in your report for heightened risk. Just again, any further clarification on Megan's report? We'll note those two items if we can, Kay, in the minutes were raised there. So the board can take assurances regarding the reports provided and the discussions that took place at the committee. Specific risks are highlighted above or in the risk register for the Finance and Performance Committee. But again, just specifically making note of those 2 points that you raised around capital and the LD health checks there. Okay, thank you, Megan. Mish, can we move into the People, Culture and Inclusion Assurance Report first, and then we'll move into the annual report afterwards and show Cat.
Great, thank you. So conscious of time, so I'm going to pull out some of the key metrics that I think that the system should be very proud of in terms of our performance. Our vacancies are at 9.3%, which is a reduction from 13% that it has been in the last 12 months. Our turnover has reduced by 2% to 8.8. And importantly, and I think it's the credit to all of the providers, our agency usage is down to 2.7%, which is actually against a target of 3.2% regionally. So that was noted in the QRSM meeting, and I think it is an inordinate amount of work by our providers to ensure that we can do that in a safe way. In terms of the rest of the report, we'd like you to note the operational plan, the workforce plan element of that. We are at good performance at month 2 in terms of our workforce plan trajectories, and we'll be on target to achieve that. Notwithstanding the conversations that we're having about the medium-term plan, the focus, the recovery plans, etc., which is of course going to be intrinsic to our ability to deliver that. We are reviewing the People, Culture and Inclusion Committee governance structure, and we'll be bringing a report to the September meeting, and also our people plan priorities, which will obviously be linked to the train, retain and reform elements.
Okay, thanks very much, Mish. And Mish, just from the report, what I took was in terms of the indicators that we were discussing with NHSE at our quarterly review meetings and monthly meetings, particularly around agency, etc. That's really coming down, I noted in the report. So the work that was put into place to deal with that is obviously working.
Yes.
Yeah, great. Okay, so any further points for Mish on the report? So we'll note the workforce position, operating plan submission, risks and mitigations in place to address. And Mish, we'll move into the annual report if we can, please.
Thank you. And again, a lot of detail in the report. The reason for the report is to assure the board and give information about all the achievements of the People programme in the last year. You'll see that there's a lot of information there that shows our collaborative approach, the new roles that we've been developing and our outreach into our wider community. So I'm not going to pull anything out in particular, but really happy to take any questions.
Okay, so a great document, and I guess these get pulled together every year, and I presume are a reference point, you know, that we can use when we're giving out information to people. But it is very helpful to actually bring all of that together into one reference point. So comments, Showkat, anything you want to raise on the annual report, the overall year?
No, Chair, the only thing I really want to say was there's been some excellent work done, and you can see how much hard work has gone in across over the last 12 months. And I think in particular, Mish highlighted, you often look for, well, okay, so what? What are those outcomes? And I think that bit around the reduction in agency spend, the level of turnover, the change in that, and the retention piece, I think is critical in terms of the wider, the whole piece around the MTFS and the transformation programme, that we have a stable workforce. So we still know there's some way to go, but it's great to see some of the interventions, what they've led to.
Yeah, green shoots, that it's going in the right direction. Megan?
Thank you. Thanks for the report. I suppose I was just reflecting on the fact that a significant proportion of our population actually have treatment outside Staffordshire Stoke-on-Trent, obviously residents of the to what extent do we work with those providers that sit outside of Stoke-on-Trent, actually are key in terms of delivering health and care for some of our residents?
In terms of the people profile?
Yeah, in terms of people. I think about their staff and how they develop is important to our residents as well as our own providers.
Yeah, it's a really useful challenge actually, Megan. What we've tended to do is to work with our internal providers that work externally. So MPFT has 50% of their work externally. What we haven't had the capacity to do at this point is to look externally to our system. Apart from our very close neighbours, for example, Shropshire, we work really closely with. But it's a very good challenge. So I'll take that back, Megan, and see if there's something that we can do more proactively to support that.
Thanks, Megan. Okay, so everybody happy then to receive for information and assurance the ICB report on delivery of people, culture and inclusion programmes for 23-24. In line with the local people plan, NHS long-term workforce plan, joint forward plan and system priorities in addressing the system workforce challenges and risks, and the ongoing support and engagement of partners in the delivery of the people, culture and inclusion programmes, which, just going back to Shokat's point, the dial seems to be moving in the right direction on many of these indicators. So thank you for that. Shokat, can I ask you to just give any highlights from your exception report as chair? Close you 17.
I think, Chad, the only thing I wanted to add was, and again, misreferenced this, is we've done a bit of a review of People, Culture and Inclusion Committee itself around the governance framework, and in particular, how across the system, chief people officers are much more integral to the work that we're doing. And as a result of that, what Misha said is we'll be bringing a further report around some proposals. We meet on a bi-monthly basis, but we think we need to step that up to meeting on a monthly basis. And it is both within the medium-term financial plan, also the operational plan, is that clear line of sight around when we talk about workforce, what are those expectations? What is it we want to deliver against the workforce? And we're just trying to develop that clear line of sight a little bit more, and the work that we do and be clear on those outcomes around workforce. So we'll bring those proposals forward, but hopefully that the governance piece around this will make sure that everything around workforce is much more aligned to everything else that's going on.
Yeah, brilliant. Thank you for that. And it's a great point in our evolution, isn't it, to reinvent our processes if we need to actually make them continually fit for purpose going forward. Thanks, Shokat. Okay, so we'll receive that. Item 17, enclosure 18, Claire, is the BAF system board assurance update. Can I hand that over to you, please?
Okay, thank you. So just a brief recap and introduction. So you'll recall we had a board development session in March where we reviewed the strategic risks, and I think it's fair to say that we carried forward everything that was on there, but we've done some refreshing and refining of the content. So this is the first version of this current year's cycle SBAF based on those strategic risks. You'll see that it's been through the committees in July, and that's been referenced in the assurance reports highlighted to you today. The formatting has had some refresh, just to keep it interesting, I think, and just to continuously improve the way in which we use the board assurance framework. In terms of some key headlines, health inequalities, workforce and finance are our top risks, and that's reflected in the scores that you will see. The majority of the risks have got a partial assurance rating. So I think it's an important point for the committees to note in terms of planning their business cycles for the coming year. Where do we need to focus attention in terms of strengthening those assurances and aligning that with the business cycles? In terms of our strategic priorities, as you would expect, given the highest level of risks, addressing inequalities and achieving sustainability are the most threatened of our strategic ambitions. The paper was considered by the audit committee, and there was a specific point raised around the alignment of BAF 6 and 7 around finances and productivity. And I think, Paul, given that you're the executive lead for both of those, that shouldn't be too much of a challenge for you to deliver on in the next update. In terms of further developments, you'll recall that we've been discussing a paper called Taking It to the Next Level, which really set out our ambitions for continuing to improve the SBAF. So I think now looking at some of the papers that you've considered in today's board meeting, I think it's really important for us to now look at moving forward with our summary SBAF that aligns with the quality of papers that you've seen today and really seeks to lift the discussion up at board level to an overarching view. So I'll work with the team around that. I think the other point that we've discussed previously, and I know that Tracy and Paul are working on, is what do the business cycles look like? Because this is, of course, about assurance, and are we receiving assurance on the key strategic risks we present? The other thing that I think we've had conversations about, and we're looking to hold a session with yourselves at an appropriate time, is around appetite and how we really play that in through the SBAF. So keen to work with yourselves on that as well. I think it's worth mentioning that following on from some of the success that we saw last year with the kind of the national profile around the work that we've done around this, I think thanks to Paul for continuously raising our profile at a national level, which resulted in him being invited along to the peer learning network earlier on in the month to share what we've done as a system. And I think it's really important that we continue to fly the flag for some of the work that we've been done. So special thanks, Paul, for doing that for us and continuing to do that. And so finally, I'll pause there, and I would defer to any relevant execs for answers to any questions on any specific risks.
Claire, thanks very much, and thanks again for all the work that's going on here to get this system board assurance framework pulled together. It's, as you say, it's continually work in progress. It'll never be completely a finished item. It's a journey we're on. And also, just thanks for pulling out the issue that Julie's referred to. She's not here today for her audit committee report, just about the alignment between 5 and 6, finance, and the productivity and efficiency piece. When I spoke to Julie yesterday, she's just keen that we actually make sure that the alignment of that is very tight. Okay, so any points on anything that either Claire's raised or the report has raised for colleagues? Okay, everybody happy? Okay, thank you. So the board is asked to discuss and confirm whether the Q1 risk scores and assurance assessments are an accurate reflection of the position, discuss the adequacy of controls and assurances, and note that the Q1 24-25 CBAF has been presented at ICB committees during July. Okay, it's the recommendation you want for today, Claire. Thank you. Item 18 is the menopause policy, and Tracy, I think I'm handing over to you to introduce this.
Yes, thank you, Chair. And as we now know, menopause is a recognised condition. So this policy looks at the impacts it has on individuals. It has been approved by the People, Culture and Inclusion Committee, has been discussed with our staff engagement group and obviously our menopause ambassadors. So there is a discussion in the policy around protected characteristics, and I've taken into account. So I'll just leave it there. It's here for ratification, has been approved by the PCI, People, Culture and Inclusion Committee. So it's for us to adopt as an organisation.
Thanks, Tracy. Just pause there for comments. I actually found this very an easy read, actually, on a very important topic and well laid out. So presumably through people, culture and inclusion mesh, that's going down well with staff that we are actually recognising this and the protected characteristics that Tracy's referred to. So can I just check with the board if there's any further comments on this, and we'll ratify the policy? Okay, thank you. Phil, another important item, penultimate item, the ICB Emergency Preparedness, Resilience and Response Policy.
Thank you.
Can I hand that over to you, please?
Yes, thanks. So the ICB EPRR policy is presented for its annual review. It's been approved by Audit Committee on the 1st of July. As part of our annual core standards assessment, it's required to be ratified by our board. So the policy essentially underpins all of the emergency preparedness activities within the ICB and sets out the ways in which we are committed to and how we deliver the duties set out under law and associated legislation. Last year, the policy was considered by NHS England to be fully compliant. So we've only made some very minor changes this year, which essentially are around terminology, changes to staffing. For example, we've got a new portfolio director who's taken on the mantle as Deputy Accountable Emergency Officer. We've also reflected the fact that we have our System Coordination Centre, and that provides additional resilience to us. And then the last point I'd flag is just that we're amending this now from an annual review to a 3-yearly review in line with NHSE's expectations, but we will amend it sooner should there be any organisational change or any change to national guidance that requires it. Thank you.
Okay, Phil, thanks very much. And again, I think it's worth just reflecting. The first time we did this assessment, we were quite harsh on ourselves, and there were quite a few amber and red ratings. I think that was 3 years ago.
So 2 years ago, the core standards assessment, we were non-compliant overall.
Yeah. And at that time, there was a real ambition to get behind this and get it fully compliant. Yeah. It's obvious from the report and the assurance we're receiving from NHSE that that's going in the right direction. So I think it's important to note that, because this is a critically important initiative. So well done to everybody involved in actually getting us to that point. Never be complacent, of course. Absolutely. You know, in terms of the way these things are assessed. So is there any other points anybody wants to raise on this policy before we ratify that? Tracy?
Yeah, you've raised it, Phil, about the change in narrative, and I suppose it's how we're going to get that into our way of speaking and way of thinking, given that we've been using the gold and silver for, well, since I was a lass, shall we say. So that might be just something we need to perhaps look at, of how we get it into our culture, that we stop using those and start using tactical and strategic.
Yes, yeah, absolutely. It's that move from silver and gold to tactical and strategic, and we'll do that. We have monthly learning sessions and refreshing sessions with all of our on-call teams. So we'll just start to use that terminology there, but it will take some time to embed naturally.
Okay, thanks, Tracy. Okay, so we're happy to ratify the policy. Thank you, Phil. The final report I think we've got is the New Style AAA Committee Highlights and Escalation Report for the Audit Committee. And Julie just wanted me to raise a couple of points. This is a new way of presenting these reports, and I hope everybody found that very helpful in terms of the presentation. And Julie was just making the point that other committees may wish to adopt that. And I think that is the plan, Tracy, in due course, that we'll make this consistent across the piece. There were two escalations that our audit chair wanted to bring to our attention today. Path 5 and 6, which we've dealt with. The second one was the external auditor's report into the continuing healthcare pillar of work. There's quite a few recommendations, Peter, in there, Paul, that Julie was keen we just make sure are linked across to the work plan, so that there can be assurance drawn back to the audit committee in due course that they've been addressed. So with that, that was Julie's escalations on that report. So everybody is happy to receive that report. Thank you. I've had no any other business advised to me in advance of the meeting. Tracy, are you aware of any that's come in since? Any urgent items? No. Anybody wants to notify? So at that point, we'll pause and invite any questions from anybody either joining us physically in the room at this time or online. If you are online, if you can use the raised hand button. If not, do it in the good old-fashioned way. Tracy?
You've got Mr. Simon in the room. I can't see any hands up on the screen.
So Ian, welcome. Can we take any questions that you may have?
Thank you, Chairman. Two more questions. One's about virtual wards and finance, they're kind of interlinked. One's about pharmacy first and pharmacy per se in general. And the first one is mental health strategy. You've got a swathe of strategies and development programs. How do you show the impact of new legislation, very specifically a new Mental Health Act and 0 hours legislation, how they impact upon your strategies and programs? And how do you publicly show those?
Okay, thank you, Ian. Nikki, do you want to pick that up? And Bucky, you may have a view as well.
Yeah, I guess as a start, what I would, sorry, I've got my back to you, Ian. What I would say is that as any new legislation comes along, one of the first things we have to do then is have a look at any impact it will have on our strategy and on our delivery plans against the operating plan. So a bit earlier on in the agenda, Paul took us through the operating plan.
Yeah, sure.
What we would do is do that assessment and try to understand the impact it's going to have and make that adjustment within our delivery plans. As you know, within our system, we've got a portfolio structure. So that would come through to the mental health, learning disability and autism portfolio. Underneath that portfolio board, we've got various groups that work on different things, and we'd ask them to look at it and look at what that means for us.
But the legislation looks as though it would be within the 3 years of the mental health strategy, et cetera, et cetera. So it's coming at you very quickly.
Yeah.
Ian, I think it's a really important point that you raise. And I guess, sorry, Nikki, I couldn't just completely hear. I think the point of a strategy is that it sets the direction, but you're not chiseling it into a slab of granite.
Yes, yes.
It's got to have sufficient flexibility to actually recognise that the landscape, the policy frameworks, etc., could change over that period. So I would expect colleagues to basically say that if the Mental Health Act legislation is revisited, and there is, a high likelihood that we're going to see a new Mental Health Act or amendments to it, then that would be addressed in terms of a benchmark exercise to actually say, how do our current services match up?
Okay.
Where would the gaps be? And presumably that new act as well may bring new streams of funding to actually strengthen some of the services for those people. And I think that goes across all the strategies, Ian, because, it has to be able to, flex to meet, that change on national policy or drivers.
Okay, to a certain extent, that is starting to lead into my next question. We know that the next year and the next few months are going to be very, very difficult financially. UH&M's July meeting, UH&M mentioned that there is £20 million of unmitigated risk being identified. Is that correct, Alan? You'll get a clearer picture when they've analysed Q1. The virtual ward situation, virtual wards, acute care at home, et cetera, are all part and parcel of your capacity planning for the surges for winter. It mentioned that Good Hope had to relocate staff onto the wards because of pressures. Good Hope is an out-of-area unit, is it not? As is Wolverhampton, as in fact, as is Queen's Hospital Burton, because it's UHDB. They're all in different ICSs, ICBs. Now, in the summer, Good Hope are under such pressure that they have to withdraw people from providing a virtual ward scheme. That's a warning sign to me. How are you going to build in the flexibility, coming back to David's point, of certain providers may, by necessity, remove staff, given that ring-fence funding for virtual wards ceased in March of this year?
Thanks, Ian. Phil, are you able to field Ian's question now? If not, we can take that offline.
Yeah, I mean, I can provide high level detail now and further detail if needed separately, but just in terms of the funding, to clarify that. So it was pump primed by NHS England. Year one was fully funded by NHS England. Year two was a 50-50 arrangement between NHS England and the ICB. Year three, which is the year we're currently in, it's fully funded by the ICB, and it's also now embedded within our baseline budgets. As I mentioned earlier, it's absolutely central to our strategy going forward. Everything that we can do around virtual wards. We've got a target overall this year to get to 420 virtual ward beds for our whole population.
Right.
And an 80% utilisation of those. So as we stand at the moment, we're at around 210, and occupancy of around 74%. We're onboarding staff all the time as we can to try and support that. As I say, the budget's available. The issue that I am aware of at Good Hope specifically is around the consultant lead from the acute care setting. Because essentially, for example, within UHM, CEDIN provides largely that consultant cover for daily ward rounds for virtual wards, and you have what's called a consultant of the week. Good Hope haven't been able to offer a consistent consultant of the week coverage, and that's what's led to some of the challenges there, but we're just working through with them now to try and address that situation. But absolutely moving forwards, virtual wards are central to our UEC strategy.
Okay.
Thanks, Phil.
Pharmacy and Pharmacy First. As I understand Pharmacy First, which has been implemented in Scotland since 2020. It's implemented in Wales, fully implemented in Wales. Pharmacy First talks about 7 conditions. And to be able to provide advice and maybe medication for those 7 conditions, there's a necessity for prescribing pharmacists. It's only in 2006 will the first graduates who have gone through a course which makes them prescribing pharmacists will become available in the market, the workforce market. Now, pharmacists that are qualified now have to do an extra year whilst they're working. So you have to pay, they have to pick up that extra year to become a prescribing pharmacist. How is that being navigated until you get the workforce that is coming out of university to provide fully for the prescribing pharmacist?
Okay. We may need to take that question offline, but I'll just ask Lorna, is there any update you can give on that?
So in terms of the pharmacies across Staffordshire and Stoke-on-Trent that currently signed up to provide the scheme, 98% of our pharmacies are currently signed up to provide and are providing. So they obviously have access to those prescribing pharmacists in some way, and we'll go away and explore what that looks like. We've had, certainly in the last 4 months, we've had 23,000 patients who've received completed treatments, which includes the prescription of medicines, go through. So it's up, it's running, it's working. But as with all workforce, there is turnover, there can be difficulty. So we will make sure that we've got plans in place to navigate that. We've got really good relationships with PCNs and GP practices so that we can manage the flow through. We talk to the ones where there aren't high referrals. We talk to the ones where there are very high referrals. There's lots of communication networks set up, and importantly, lots of data monitoring that we're doing in terms of outcomes to make sure that things like workforce shortages aren't resulting in patients being referred but then bouncing back into practice or other portals.
Could I quickly come back on that? It's the timeliness of this, because Pharmacy First is obviously set up to take pressure off GPs. And pharmacy is one of the 4 pillars, isn't it, of primary care, along with ophthalmology, dentistry and GP practices. Right. It's the timeliness, for a user of the service, if you have to wait 4 to 5 days to be able to access Pharmacy First, it becomes nigh on useless. Can you see where I'm coming from, Connie?
Absolutely. And access is something that is very important to patients, but it's also very important to us. So we are keeping a close eye on that. The time it takes for people to access the service is one of the things that we monitor regularly, and we have all that collated into a big dashboard. So if it would be helpful, we can take that offline and give you some assurance about just exactly how we're keeping track of all those things.
Okay.
Thank you very much.
Ian, thanks for your interest and your questions. Tracy, can I just check, has anything come in online?
Margaret's put a hand up.
Right.
Hello, thanks very much indeed. Just very quickly, it's a comment much more than a question, I think. I'm just picking up on the points about external providers. Good Hope's been mentioned a lot, but you've got Derby, you've got Burton, Wolverhampton, etc. And I've been this is the first time I've actually managed to join online. I'm just picking up the point that it's absolutely fine while you're dealing with Staffordshire and Stoke and your local and the hospitals which are within that remit and other providers. And I'm sitting here in Lichfield thinking we're right down in the bottom. We get pushed from pillar to post. And listening to everything, plans sound absolutely fabulous, amazing amounts of work, etc. But I'm just wondering where we sit. We have a local hospital which needs, which could provide many more services, needs upgrading and probably in many ways. But, you know, we're just sitting here on the dewdrop end of the county. When I lived in Sutton Coldfield, we were the weak partner of Birmingham. And it feels as if Lichfield, along with Tamworth, are the weak partners of Staffordshire, and particularly Stoke-on-Trent. Thank you for your time.
Yeah, Margaret, thank you for the comment, and we'll note those comments. And I'm sure, Lorna, those comments will feed back in terms of the specific issues around Lichfield.
Absolutely.
Okay, thank you, Margaret. Tracy, any further calls? And just check if there's anybody else in the audience wishes to raise any points with the board. Okay, thank you very much. Sorry, David.
No, not at all. I just wanted to make a few comments, if that would be helpful. 6 comments, really. Listening to, you know, what's an excellent meeting. On workforce, what a number of the ICSs are doing is that they've kind of recognised that we have nationally something around about 5 million carers, unpaid carers, and they've taken steps to find ways of supporting those unpaid carers, that they can do more of the load that's currently being carried, you know, in the primary and secondary care. So that's my first point. The second one is the significance of today, which is enormous in the sense it's the release of the first report on the COVID review.
Yeah.
I guess you've all been so busy today, you haven't had a chance to read it yet. But what it's all about, of course, is preparedness. And it highlights a kind of refusal to learn from some of the lessons. And, you know, I'm just minded that, you know, one of the big problems that we faced was the belief that all pandemics would be like flu, whereas those countries in which we had SARS regarded all future pandemics would be like SARS. And of course, the way that you deal with those, as your colleagues know, is entirely different. So I just raised that today because there'll be a lot of learning that comes out of that.
Sure.
The third point, Peter, is something that you talked about when you were talking about system, place and neighbourhood. When I reviewed what the Alzira system could bring us compared to others. One of the fundamentals was the work that they did at neighbourhood level, which was then some of it put up to place level, and then some of that to system level. And I don't think that's something that many of the ICBs have really taken on board. They've tended, I think partly because, of course, of the horrendous financial pressures to deal with sorting out things at system level and then, you know, trickle down. And I don't think trickle down works. Trickle up, I would advertise. My fourth point is, you know, something you guess, you will know, but the involvement of former New Labour architects, you know, from Tony Blair, Alan Milburn, Paul Corrigan, Peter Mandelson, Ari Darcy, that gives you a very clear idea of where the emphasis of change will be in the future. So I, just draw that to your attention. I'm sure you're aware of it, but they are very powerful players in the way that we're going to develop the whole of the health and care system over the next few years. And a point that Phil mentioned when he was talking about waiting lists, I think that the government's going to really deconstruct a lot of these waiting lists, and they're, for example, going to be looking very much at what is the waiting list for diagnosis of things like autism, of ADHD, of dementia. And I know that currently there are quite a large number of people nationally, Phil, who have waited more than 3 years already to get a diagnosis of autism, ADHD. Now, that means during that period, they're not able to get medical treatment. And therefore, the condition after 3 years is arguably less remediable than it would have been earlier. So my sixth, and you'll be merciful to know the last one, is on inequalities. And I think my experience from other countries is that where the addressing of serious inequalities has been particularly successful is when it has been dealt with by understanding the hegemony of individual disadvantaged or marginalized groups and working through that existing hegemony to get to the people, because that gives an endorsement of our right to actually go to those people. And without that endorsement, it becomes very difficult to access those. Those are my points.
Great. Thanks very much, David. Always helpful to receive those reflections. And the point you made about the assembly of some of the people, as you say, it is a clear indicator of where we are we're moving into in the territory. Okay, so we're almost out of time, just 2 minutes away from the end of the meeting. I just wanted to go back to the point I made about the compact at the start, and just wanted to check that everybody around the board table has felt that we've lived those values and behaved in the way that we set out there, and that everybody has had ample opportunity to raise anything or discuss anything that they wanted to during the course of today. If not, speak now or forever hold thy peace. And on that point, we will draw the meeting to a close. There is no meeting in August. The date and time of our next meeting will be the 26th of September, and that will be held in public over Microsoft Teams. So can I thank everybody who's joined us online and in person today for their attendance and interest, and thank board members for everything that's been presented and discussed during the course of the meeting. Meeting closed.
Thank you, David. Thank you. Thank you very much.